Welcome back to the Deep Dive. We have a very interesting stack of papers on the desk today. It's quite a mix, isn't it? It is. At first glance, it looks like a standard medical review. We've got clinical guidelines from the CDC, pathology reports, some excerpts from medical history books.
The usual suspects.
Exactly. But we are going to start this deep dive in a slightly different place than usual. We aren't starting with a patient zero or a breaking news headline. We're starting with a test.
Specifically, we are going back to a medical residency exam question from the year 2006.
Right. And I want to be clear to everyone listening right off the bat. We aren't doing this to help you cheat on a board exam from 20 years ago.
Yeah, statute of limitations is probably passed on that one.
I would hope so. No, we aren't prep tutors. But as we went through the source material, it became obvious that this single multiple choice question is actually a masterclass in observation. It's a perfect gateway.
It really is, because if you can properly deconstruct this one question, you understand the entire biological strategy of a disease that has been with humanity for centuries. We're talking about Chancroid,
which is known in English medical terminology as Chancroid.
That's the one.
Chancroid. It's a condition that sounds archaic, almost Victorian, like something you'd read about in a Dickens novel or a ship's log from the 1800s.
It has that feel, doesn't it? But it's very much a modern problem.
And that's the mission today, to take this find the exception question, rip it apart, and figure out the biology, the history, and the treatment.
And by the time we're done, you won't just know the answer to the test.
No, you'll understand why Tasmanian devils and spotted hyenas are weirdly relevant to human sexual health.
And why the immune system of a codfish might just explain why this disease is so uniquely painful.
Exactly. So let's set the stage. The source material is a clinical breakdown of Chancroid. It covers histology, that's the microscopic study of tissue diagnostics, and treatment protocol.
But everything pivots around the central premise. Medicine is often about distinguishing between things that look identical but act completely differently.
That is the core skill of diagnostician, isn't it?
It's everything. You have 3 patients with ulcers. They look roughly the same to an untrained eye, but one is syphilis, one is herpes, and one is Chancroid. The exam question from 2006 was designed to see if you could spot the fundamental biological difference in how Chancroid behaves compared to its cousins.
Okay, let's put the listener in the shoes of a nervous medical student. The year is 2006. The air conditioning in the exam hall is probably too loud. You're stressed.
Sweaty palms, the whole deal.
The whole deal. You open the booklet and you see this prompt regarding Chancroid. It says, all statements are correct except PT. And it lists 4 options. Your job is to find the lie.
The classic negative STEM question. Always a bit of a mind bender.
So let's hear the options. Walk us through them.
All right, let's lay them out.
Okay. Option A. Systemic infection does not occur.
Straightforward enough. Option B. It is caused by Haemophilus ducrea, a gram-negative bacillus.
That's your basic microbiology fact check.
Option C. Prodromal symptoms of this infection are common and include fever, malaise, myalgia.
Okay. The clinical picture.
And finally, the beast. Option D. Characteristic histological findings show 3 vertically arranged zones. A superficial necrotic zone, below that a zone of vascular neoformation, and deeper a zone of lymphoplasmacytic infiltrate.
Wow. Talk about a spread of difficulty there. You have basic microbiology in option B, and then you have incredibly specific, almost esoteric tissue pathology in option D.
It feels designed to panic you, especially that description of the zones in option D. It sounds so authoritative, so technical.
It does. It has the ring of truth.
I feel like if I didn't know the answer, I'd assume that one was true just because it uses the word lymphoplasmacytic.
It's a classic test writer's trick. The most complex sounding answer is often either the correct one or a very convincing red herring.
Well, we are going to spoil the ending right now so we can dissect why. Which one is the lie? The lie, the exception, the correct answer to the question is option C.
Option C. Prodromal symptoms are common and include fever, malaise, myalgia. That is the false statement.
Correct. And this is the crux of the entire deep dive. To understand why C is wrong is to understand what Chancroid is.
I want to pause on that word prodrome. We see it a lot in the medical literature, but let's make sure we're all on the same page. Define that for us.
A prodrome is that early warning phase of an illness. It's the prequel to the main event. It's before the specific rash appears or the specific organ failure happens.
It's when you just feel off.
Exactly. It's when you feel flu-like, you have a fever, your muscles ache, that's myalgia, and you feel a general sense of unease or discomfort, which we call malaise.
And that happens because the infection has gone systemic.
That's the key. Systemic.
Meaning it's in the blood.
Exactly. It's in your bloodstream, triggering a whole body alarm system.
Yeah.
The cytokines, the chemical messengers of the immune system, are flooding your entire body.
They're not just at the site of infection anymore.
No, they're everywhere. They're telling the brain to turn up the thermostat, which gives you a fever, and telling the muscles to ache. It's a global response.
So if I have syphilis or HIV or even the common flu, the pathogen is traveling through my bloodstream, so my whole body reacts.
That's it. The alarm rings in every room of the house because the burglar is running through the hallways. But Chancroid. Chancroid is a localized tegumentary infection.
Tegumentary. That's a great Scrabble word.
It is. It just means relating to the skin, or a covering. Haemophilus ducreae, the bacteria responsible, is an invader that sets up camp in the skin and the local lymph nodes.
So it's a home invasion, but it stays in the foyer.
Perfect analogy. It digs in, it creates a fortress in the entryway and maybe the adjacent hallway, which is the lymph node, but it does not travel to the liver, the lungs, or the brain. It doesn't enter the bloodstream in a way that causes that systemic fallout.
So the trap in the exam question is common sense. You see a patient with a horrible rotting ulcer and swollen glands. It looks incredibly angry. You assume they must have a fever.
You think so, right?
You assume they must feel sick all over.
But they don't, not typically. Unless they are severely immunocompromised, for instance with advanced HIV, their body temperature is normal, their energy levels might be fine, apart from the misery of the pain itself.
So the war is strictly contained to the genital region.
And the regional lymphatics, that's it. If you marked C as true on that exam, you fell for the trap of assuming that severe local inflammation automatically equals a systemic illness, and that's a mistake.
That's a crucial distinction. Syphilis is often called the great imitator because it goes everywhere and mimics everything.
It's a master of disguise.
Chancroid then is the local destroyer.
Precisely. It's a localized war zone versus a global conflict. It's intense, it's destructive, but it's contained.
Let's move from the exam paper to the clinic. The source material uses the phrase, the clinic is sovereign. I love
Me
that.
too, it's very dramatic.
It sounds like something you'd put on a banner. But I assume that means the physical examination trumps the lab tests.
It does, largely because the lab tests for Chancroid are notoriously difficult, which we'll get to later. But yes, you have to know what this looks like. You have to trust your eyes and your hands, and honestly, it's a grim picture.
The definition is multiple, extremely painful genital ulcers. But the sources use very specific adjectives to describe these sores: dirty and soft.
Right. Let's break those down because they aren't just casual descriptions, they are diagnostic terms. When a doctor says an ulcer base is dingy, they aren't judging the patient's hygiene.
No, it's a technical term.
It's a technical term describing the wound bed itself.
So what makes it dirty? What are you seeing?
You're seeing a necrotic, purulent exudate. That means dead tissue and pus. It's a gray or yellowish layer of biological debris. It looks ragged, shaggy.
So how does that compare to, say, syphilis?
The classic chancre of primary syphilis is usually clean. It's a punched-out ulcer with a red, shiny base. It looks like fresh raw meat or clean granulation tissue. Syphilis looks tidy, chancre looks dirty.
And the soft part, hence the name Chancroid soft chancre.
This is tactile. If you, with a gloved hand, please palpate the base of a syphilis ulcer, it feels hard. It feels indurated.
Indurated.
It's like there's a button or a piece of firm cartilage under the skin. That's why syphilis is the hard chancre.
So you can feel a defined, firm edge.
A very firm base. Now with chancroid, if you palpate that, it feels soft, ragged, and undefined. There's no structural integrity to it. It just feels like mushy, inflamed tissue. It's friable, meaning it bleeds easily on contact.
And then there's the pain factor. The text emphasizes this heavily. It seems to be the one thing the patient notices first.
It's the headline feature. It's the defining characteristic. Syphilis ulcers are often completely painless because the nerves are damaged in a specific way or the inflammation is different.
So you could have a syphilis ulcer and not even know it's there?
Absolutely. You could have a massive lesion with syphilis and not even feel it. You might only notice it when you look in the mirror or during a routine checkup.
But chancroid is the opposite.
Excruciating. The sources note that patients often refuse to let the physician touch the area for examination because the pain is so intense, they'll literally jump off the exam table.
That seems like a massive red flag for diagnosis. If the patient is screaming, think chancroid. If they're indifferent to the touch, think syphilis.
As a rule of thumb, yes. It's one of the first branches in your diagnostic tree. Painful versus painless, soft versus hard, dirty versus clean. Those three dichotomies can get you most of the way there.
There's one more visual clue the sources mention. Kissing ulcers. It sounds almost poetic, but given what we've described so far, I suspect the reality is gross.
It is less romance, more infection. It's a phenomenon called autoinoculation.
Autoinoculation, so self-infection.
Exactly. Because the ulcer is teeming with bacteria in that dirty pus, if the sore touches the skin on the opposite side, say the other thigh or the opposite labia, it plants the bacteria there.
Just from contact, from the surfaces touching.
It's from touching, the bacteria are transferred, they find a microabrasion, and they start a new colony. A new ulcer forms that mirrors the first one. They look like they are kissing.
And that's a hallmark of chancroid.
It is. Syphilis doesn't usually do that. If you see mirror image ulcers, you have to think Haemophilus ducreyi. It tells you how incredibly infectious that surface pus is.
So the bacteria is easily transplantable. That makes sense given how aggressive it is locally. And that brings us to the bubo.
The bubo, yes. This is the swollen lymph node in the groin, inguinal lymphadenopathy.
Now, wait a minute. I want to circle back here. The exam question said systemic infection doesn't occur, but the lymph nodes are involved. Isn't that systemic?
That's a great question, and it's a point of potential confusion. The answer is no, not in the way we mean for a prodrome.
Explain that.
The inguinal lymph nodes are the regional drainage for the genitals. Think of them as the local police station for that specific neighborhood. The bacteria gets carried there by the lymphatic fluid, but the immune system traps it.
So it's contained within the local jurisdiction.
Exactly. It becomes a localized battleground. The node swells, it becomes red and painful, and it undergoes liquefaction.
It turns into liquid.
The inside does, yes. The inflammation is so intense that the tissue inside the node dissolves into pus. The node becomes a literal bag of pus, what's called a fluctuant mass.
A bag of pus.
And this leads to a critical diagnostic sign regarding how it bursts.
Because it wants to get out. That pressure has to go somewhere.
It has to. In another disease, lymphogranuloma venereum, or LGV, the bubo tends to become matted together and then burst through multiple holes, looking like the nozzle of a watering can. It's called the groove sign.
A watering can, okay.
But in chancroid, the bubo usually bursts through a single point, unilocular drainage.
A single dramatic rupture.
Exactly. It's a high-pressure failure of the skin at one weak point. It creates a large, draining fistula. It's another one of those clinical pearls that helps you differentiate.
We need to talk about the stakes here. It's painful, sure, it's unsightly, but the source material flags a much darker connection, HIV.
This is probably the most critical public health takeaway of the entire deep dive. Chancroid is described as a major cofactor for HIV transmission.
Describe that synergy. Why does one help the other?
Think about the biology we just described. You have a breach in the skin, an open door, that's problem number one.
Right, a way in.
But it's not just a hole, it's an inflamed hole. The body is rushing immune cells to the area to fight the Haemophilus bacteria.
Sending in the troops.
Specifically, it sends CD4 positive T cells and macrophages.
And CD4 cells are?
They are the exact cells that HIV targets. They are the primary host cells for the HIV virus. It's what the virus needs to replicate.
Oh, wow.
So by having a chancroid ulcer, you have essentially rolled out a red carpet composed of HIV's favorite food. You are recruiting the target cells right to the surface of an open wound where the virus can easily find them.
That is terrifying. It's like you've set up a buffet for HIV right at the point of entry.
It's the perfect storm for transmission. The risk of acquiring HIV if you're exposed during sex is massively amplified if you have an active chancroid ulcer. And conversely, if you're HIV positive, you're much more likely to transmit the virus to a partner through that same ulcer.
A two-way street.
A very dangerous two-way street, which is why rapid treatment isn't just about pain relief or curing the ulcer. It's a frontline HIV prevention strategy. In regions where both HIV and chancroid are prevalent, treating chancroid is a critical public health intervention.
That recontextualizes the localized nature of the disease. It stays in the skin, but it opens the gate for a systemic killer.
It's a local problem with potentially global consequences for the patient.
Let's look under the hood. We're moving to the pathophysiologically speaking section. We know the culprit is Haemophilus ducreyi. What is this thing?
It's a gram-negative coccobacillus. So it's a short, rod-shoot bacterium that stains pink with a gram stain. And it's a fascinating organism because it's a strict human pathogen.
What does that mean, strict human pathogen?
It means it doesn't have an environmental reservoir. It doesn't live in dirt, it doesn't live in water, and it doesn't live in animals, with some weird exceptions we'll mention later. It mostly lives in us. It passes from human to human.
So it's completely adapted to us.
It is, but it's an opportunist. It cannot chew through intact, healthy skin.
So if you put it on the back of your hand, nothing happens.
Correct. It needs a door, it needs a microabrasion.
A tiny scratch.
A tiny, often invisible scratch that occurs during the friction of intercourse. That's all it takes. Once it's in, it plays a very aggressive game.
How so?
It produces a very specific and nasty toxin called cytolethal distending toxin, or CDT.
Let's break that name down. Cytolethal. Cell deadly.
Right, and descending means swelling. This toxin enters the human cells, specifically the keratinocytes, which are the main skin cells, and fibroblasts, the cells that build connective tissue.
And what does it do inside the cell?
It's a genotoxin. It attacks their DNA.
It damages the DNA.
Specifically, it causes double-strand breaks in the DNA. It's like taking a pair of scissors and snipping the rungs of the DNA ladder.
And the cell can't handle that.
The cell has checkpoints. It realizes its DNA is catastrophically broken, so it arrests the cell cycle. It stops dividing, it swells up, that's the descending part, and eventually it undergoes apoptosis. It commits suicide.
So the necrotic base of the ulcer isn't just a byproduct of inflammation. The bacteria is actively poisoning the tissue to create a dead zone.
It is. It's chemical warfare at a microscopic level. It's clearing space for itself by killing the host cells. But there's a second factor at play, which is just as important.
Which is?
The body fights back, and it overreacts. It sends waves and waves of neutrophils, those white blood cells that act as the first responders, the shock troops.
These are the suicide bombers of the immune system, right?
That's a good way to think of it. They rush in and they release toxic enzymes and oxidative chemicals to kill bacteria. But H. ducreyi has evolved ways to resist being eaten, a process called phagocytosis.
So the neutrophils can't get a handle on it.
Right. They get frustrated, they pile up in the thousands, and they just release their toxic granules into the surrounding area, dissolving both the bacteria and the human tissue indiscriminately.
Friendly fire.
Massive friendly fire. The thick, purulent pus you see in a chancroid ulcer is largely a soup of dead neutrophils and liquefied human tissue. The bacteria is actually causing our own immune system to do most of the tissue damage.
And the bacteria just sits in the middle of this chaos.
It does. It actually has adhesion proteins that allow it to stick to the bottom of the ulcer despite this torrent of pus and fluid trying to wash it away. It anchors itself in the carnage it created. It's a very resilient bug once it establishes that foothold.
That sounds incredibly difficult to treat if the bacteria is digging in like that. But before we cure it, we have to prove we have it. The diagnostic approach.
This is where it gets tricky in the real world.
The sources use a visual metaphor that I love.
Yeah.
The school of fish.
Or railroad track.
Explain that. What are we looking at?
This refers to what you see under the microscope with a Gram stain. A Gram stain is the most basic test in microbiology where you dye bacteria to see their shape and cell wall type.
Right. Gram positive is purple, gram negative is pink.
Exactly. Haemophilus ducreyi is Gram negative, so it stains pink or red. And they are cocobacilli little ovals. But they have a social behavior. They don't just float around as individuals.
They don't float alone.
No, they clump together in parallel chains. So when you look through the lens, you see these drifting currents of pink dots all lined up looking exactly like a school of fish swimming together in a stream or the parallel ties of a railroad track.
That is such a specific and memorable image. Is that how doctors diagnose it in 2026? Do they pull out a microscope in the office?
Ideally, yes. In a well-equipped STI clinic, they might. In reality, rarely. The source material is very honest about this. The sensitivity of a Gram stain from an ulcer is low, maybe only 50%. You can easily miss it.
So what's the other option?
The gold standard is culture growing the bug in a petri dish. But H. ducreyi is a diva.
A diva? What do you mean?
It is fastidious. That's the microbiological term for picky. It requires very specific blood-enriched media, usually with added growth factors. It needs high humidity. It needs a specific temperature and CO2 concentration.
So it's high maintenance.
Extremely. If you just swab it and send it to a standard hospital lab, it often dies before it gets there. Or the lab doesn't have the right kind of special agar plate, so it refuses to grow. Most standard hospital labs will fail to grow it.
And PCR. DNA testing must be the answer.
PCR is great. It's highly sensitive and specific. But again, think about the epidemiology. This disease is most common in tropical, developing nations in resource-limited settings. You often don't have a PCR machine down the hall. It's expensive and requires expertise.
So in many parts of the world, we fall back on the syndromic approach.
Which is doctor speak for making an educated guess based on the clinical picture. You use the big 3 flowchart that we talked about. 1. Is it syphilis? Check for a hard, painless ulcer. No. 2. Is it herpes? Check for blisters, vesicles, a burning sensation, and a history of recurrence. No. Then it's probably chancroid.
It's a diagnosis of exclusion.
For a lot of the world, yes.
Yeah.
It hurts too much to be syphilis, and it's a single deep ulcer, not vesicles, so it's not herpes. We'll treat for chancroid.
Let's circle back to that terrifying option D from the exam, the histology, the one about the 3 vertically arranged zones. Was that actually true?
It was. It's the deep cut for the pathology nerds. This description comes from a classic histopathological study, sometimes called the Sanderson and Sheldon triad. It's a textbook observation from the mid-20th century.
Why were they so specific about layers? It sounds like they were doing an archaeological dig on a biopsy.
Because it shows the timeline of the battle. If you take a biopsy, which again we rarely do because it hurts like hell and isn't necessary for treatment, you see the war strategy laid out in layers like geological sediment.
Okay, walk me through the layers, top down.
Zone 1, the top layer, is the superficial necrotic zone. That's the battlefield we just described. Dead tissue, fibrin, dead neutrophils. It's the dirty layer you see with your eyes.
That's the pus and grime.
Exactly. Then you go deeper to zone 2. This is the zone of vascular neoformation. This is the body trying to repair itself. It's growing new blood vessels, a process called angiogenesis, to bring in supplies and oxygen to the front lines. It's also where you see a lot of edema or swelling.
So that's the supply line.
That's the supply line. And then deepest of all, you have zone 3, the lymphoplasmacytic infiltrate. This is the command center.
Who hangs out in the command center?
Plasma cells and lymphocytes. These are the cells of the adaptive immune system. They're the specialists. The plasma cells are churning out antibodies, and the lymphocytes are coordinating the long-term immune response. They're hanging back from the neutrophil chaos at the surface, trying to direct traffic.
It's incredible that you can see the war strategy, frontline, supply line, command center laid out physically in the tissue.
It is. It validates that option D was technically correct, even if it's a level of detail most doctors will never see in practice. It's the classic textbook knowledge versus street knowledge gap. But for an exam, you need the textbook.
Okay, we've diagnosed it, we've looked at the layers, now let's cure it, the therapeutic approach.
The good news is that unlike viruses, herpes, or HIV, this is a bacteria. We can kill it and kill it effectively. The CDC and WHO guidelines list 2 main weapons, azithromycin and ceftriaxone.
Azithromycin is the pill, the Z-Pack.
Right, but for chancroid, it's even simpler. It's just a single 1 gram dose, 1 pill, once. Very convenient.
And ceftriaxone.
That's a single intramuscular injection, 1 shot. Also very convenient, especially for directly observed therapy where you can ensure the patient gets the full dose.
The source mentioned something interesting about why azithromycin is the preferred choice beyond just convenience. It's not just about patient compliance.
No, it's about pharmacokinetics, how the drug moves and works in the body. Azithromycin has this unique ability to concentrate inside macrophages and other white blood cells.
The immune cells that are rushing to the ulcer.
The very same ones. Remember, macrophages are the heavy tanks that rush to the site of inflammation to eat debris and bacteria. Azithromycin essentially hitches a ride on the immune system's taxi service. It gets carried inside the macrophage directly to the ulcer.
That is a Trojan horse strategy, but for the good guys.
Exactly. The concentration of the drug in the inflamed tissue becomes many, many times higher than the concentration in the blood. And it stays there for a long time. The half-life is very long.
So you take 1 pill, and the drug is fighting the war at the site of the ulcer for days, long after the pill has left your stomach.
It's highly targeted drug delivery, using the body's own inflammation as the targeting mechanism. It's incredibly elegant pharmacology.
That is smart. Now let's talk about the bubo again. If I have a painful liquid-filled lump in my groin, my instinct says cut it open and drain it. It feels like a boil. I want relief.
And that instinct, while understandable, would be wrong. The guidelines are emphatic. Do not perform an incision. Do not take a scalpel to a chancroid bubo.
Why not? We drain abscesses all the time.
Because this tissue is fragile, highly inflamed, and heavily infected with a tissue-destroying bacteria, if you slice it open, the edges of the wound will not heal. The bacteria and the intense inflammation prevent the skin from knitting back together.
So you create a bigger problem.
You end up creating a chronic fistula.
A fistula.
A permanent, or at least very long-lasting, draining tunnel. It refuses to close, so you trade a temporary, painful lump for a permanent open hole that leaks pus for months. It's a terrible trade-off.
So what do you do instead? How do you relieve that pressure?
Aspiration. Needle aspiration. You take a large gauge needle, a thick one, like an 18 gauge, and you insert it through healthy skin next to the bubo, not directly through the inflamed red center.
You go in from the side.
You go in from the side, tunneling under the skin until your needle tip is in the center of the pus pocket. Then you suck out the pus with a syringe.
Like using a straw.
Effectively. You relieve the pressure, you remove a large part of the bacterial load, but you leave the skin structure intact. You might have to do it 2 or 3 times over a week as it refills, but eventually the antibiotics kick in, the inflammation subsides, and the skin heals without leaving a gaping hole.
It relieves the pressure without breaking the container.
Exactly. It's a delicate procedure for a very delicate and painful area.
Let's zoom out to the anatomo-topographic approach. We touched on the fact that this happens in the genital region. But the sources bring up a specific factor regarding circumcision.
The circumcision factor is statistically huge. Across numerous studies, uncircumcised men are significantly more likely to contract chancroid than circumcised men. In some studies, the risk difference is dramatic, like a 3 to 8-fold increased risk.
Is that just a hygiene issue?
It's partly hygiene, yes. The subpreputial space, the area under the foreskin, creates a warm, moist pocket that H. decree absolutely loves. It thrives in humidity.
So it's a good incubator.
It's a perfect incubator,
Yeah.
but it's also about the armor of the skin itself.
Armor? What do you mean?
Think about skin texture. When the glands, the head of the penis, is constantly exposed to air and friction due to circumcision, the skin on its surface undergoes keratinization.
It gets tougher. It calluses over in a way.
Exactly. It becomes more like the skin on your elbow versus the thin, delicate skin inside your cheek. That thicker keratin layer makes it much more resistant to those microabrasions we talked about. If the skin is tough, it doesn't scratch as easily. If it doesn't scratch, the bacteria can't get in.
And the inner foreskin?
The inner foreskin is essentially a mucosal surface. It's thinner, softer, and tears much more easily. It's also highly vascular. It's the perfect entry point for the bacteria, so circumcision removes that vulnerable tissue and hardens the remaining surface.
So it provides a very real structural defense.
It acts as a biological hardening of the target. This is one of the reasons the WHO recommends male circumcision as part of a comprehensive HIV prevention strategy in high prevalence areas, because it reduces the risk of ulcerative STIs like chancroid that facilitate HIV transmission.
I promised at the beginning we talked about animals. The section is titled Secrets of the Animal Kingdom. I didn't expect to see Tasmanian devils in a file about an STD.
This is where we look at the biology of localized aggression and transmission across species. Nature repeats patterns. The Tasmanian devil, Sarcophagus harisi, suffers from something called devil facial tumor disease.
That's the contagious cancer, right? It's been devastating their population.
Yes. It's one of the only known clonally transmissible cancers. It spreads when devils bite each other in the face during fights over mates or food.
So it's transmitted through trauma.
Exactly. It creates these massive ulcerating wounds on their faces that, if you look at pictures, look remarkably like giant, horrifying chancroid ulcers. The parallel is the transmission method. Direct contact plus trauma plus breach of skin barrier. It reinforces that our skin is our primary defense. Once that integrity is breached, whether by a bite for the devil or a sexual abrasion for the human, the pathogen, or in the devil's case, the tumor cell takes hold.
It's a universal principle of infection. Find the broken wall.
Exactly. And then there's the hyena.
The spotted hyena, Crocuta crocuta.
Yes. The female anatomy here is, well, it's extreme. The female has a pseudopenis. It's an elongated clitoris that she has to both mate and give birth through.
That sounds mechanically difficult. A design flaw, even.
It results in severe genital lacerations during birth and copulation. The source uses this to illustrate trauma as a gateway. For the hyena, these tears aren't an accident. They're a standard part of their life cycle, and they're the standard entry point for all sorts of infections. It shows that in the animal kingdom, genital trauma is a common vulnerability.
So for humans, we don't need such dramatic trauma. Microabrasions are enough. But the principle is the same. The pathogen exploits the wound.
It's a matter of scale, not of principle.
And finally, the Atlantic cod. What on earth does a fish have to do with this?
This connects back to the pus and the friendly fire we talked about earlier. The Atlantic cod, Goddess morwa, has a very strange immune system. For reasons we don't fully understand, it completely lacks the MHC-T system.
The MHC2. Remind me.
That's a crucial part of the adaptive immune system. It's the molecular machinery that our cells use to present fragments of invading pathogens to our T helper cells. It's essential for developing immune memory and a coordinated attack.
So the cod doesn't have that?
Nope. It's like an army without good intelligence officers. To compensate for this, it has a hyperactive innate immune system. It relies heavily on neutrophils. Its primary strategy for any infection is to just bomb the area with neutrophils.
So it just bombs everything, regardless of collateral damage.
Essentially. And in chancroid, the human response mimics the cod. We see a massive, disproportionate rush of neutrophils to the site. The tissue destruction in chancroid is arguably caused as much by our own cod-like neutrophil response as it is by the bacteria's toxin itself.
It's a primitive, messy defense strategy.
It is. In this specific infection, our advanced immune system reverts to a more ancient, brutal form of immunity, just throwing bodies at the problem. And the result is necrosis and pus.
We can't finish without nodding to the history worthy of a Nobel. Who are the giants whose shoulders we're standing on here?
We have to start with Auguste Ducret. He worked in the 1880s, and he's the namesake of the bacterium.
And he was a bit of a mad scientist by modern standards.
He was operating in the era before ethical review boards. He was faced with this huge question. Were the hard, painless chancres and these soft, painful ulcers just different forms of syphilis, or were they totally different diseases?
A major diagnostic challenge at the time.
A huge one. So to prove they were different, he performed auto-inoculation experiments.
He injected people with pus.
He took pus from a patient's soft ulcer and injected it into their arm or even his own skin to watch the characteristic painful ulcer grow. He showed it was transmissible and that it always produced the same type of sore, fulfilling what would later be known as Koch's postulates.
Wow. That is dedication, if nothing else.
It was crucial work. He proved unequivocally that chancroid was a distinct entity. It allowed medicine to finally separate the two diseases and stop treating them as the same thing.
Then we have Paul Ehrlich, Nobel winner in 1908.
The father of chemotherapy, and importantly here, staining. Without his pioneering work on how different chemical dyes bind to different cells and bacteria, we wouldn't have the Gram stain. We wouldn't be able to see that school of fish.
Yeah.
He gave us the glasses to see this invisible world.
And finally, a name everyone knows. Fleming and his colleagues Florey and Chain. The antibiotics.
This is the most profound change of all. Before 1945 and the widespread use of penicillin and later antibiotics, chancroid was a sentence of months of agony. It could cause severe genital mutilation and social isolation. There was no cure. You just used topical salves to manage the pain and hoped it didn't eat away too much tissue.
And after penicillin and other antibiotics.
It became a nuisance that disappears in a week with a single pill or a single shot. It turns a flesh-eating monster into a minor treatable inconvenience. We really, really take that for granted. The difference between months of agony and one pill of azithromycin is the entire story of modern medicine in a nutshell.
So let's wrap this investigation up. We've gone from a 2006 exam hall to 1889 Naples and back again. If our listener is ever faced with that exam question, or perhaps just wants to be the smartest person at the bar trivia night, what are the key takeaways?
Let's recap the dossier.
Haemophilus Ducret. Gram-negative hangs out in schools. The crime scene. A painful, dirty, soft genital ulcer, sometimes with a kissing cousin on the other side. The alibi, or rather, the lie from the test. Systemic symptoms. There's NO fever, NO flu-like illness in a standard case. It stays local.
Don't let the sight of all that pus and inflammation fool you into thinking the patient is septic. In chancroid, the body keeps the fight local.
And the mnemonic regarding syphilis.
Chancroid hurts, syphilis doesn't, and soft versus hard. If you remember those two things, you've got 90% of the clinical diagnosis down.
Before we sign off, the source material had one final slightly unsettling note. A provocative thought.
Yes, this is where it gets interesting again. We spent this whole hour calling chancroid a sexually transmitted infection, an STI. But recent epidemiology, especially from the Pacific Islands like Vanuatu and Ghana, is challenging that label.
How so?
They are finding Haemophilus Ducret as a major cause of chronic skin ulcers on the legs and feet of children.
Children who are clearly not sexually active.
Exactly. The same bacteria causing the same kind of necrotic ulcers, but transmitted through non-sexual skin-to-skin contact, probably in crowded living conditions with poor hygiene.
So the bacteria might not be an STI at all.
It suggests that the bacteria might be, more fundamentally, just a skin pathogen that exploits any skin-to-skin contact, thriving in poor hygiene or humid conditions. In adults in the developed world, sex is just the most common and efficient form of that specific kind of skin-to-skin friction.
That blurs the lines of our neat medical categories.
Yeah.
It means the school of fish might be swimming into new waters we hadn't considered.
It's a humble reminder that biology doesn't care about our textbooks or our definitions. It adapts, and we have to adapt with it.
Well, on that note, thank you for guiding us through the painful, fascinating, and historically rich world of Chancroid.
My pleasure. Stay curious.
And stay protected. We'll see you on the next deep dive.